Welcome to ANCAN's Active Surveillance Support Group. We're a support group for those on active surveillance and not getting treatment and who haven't had treatment for prostate cancer. I first would like to thank our sponsors, Bayer, Pfizer Oncology, Novaritis, Foundation Medicine, Johnson & Johnson, Myriad Genetics, and Blue, help me out here, Hugh.
Blue Earth Diagnostics.
Blue Earth Diagnostics. And Foundation Medicine, which I think I said, but I'll say it again just in case. Are there any new people here today?
No.
No. Okay. Anybody that I didn't ask yet if they needed time? No. Okay. Then why don't we start with you, Gary?
Oh, okay. Yeah, I went for a my annual every 6 months PSA, and went down from 7.8 to 7.2, which is a good thing. Yep. For the first time, it was they tested free PSA, and to be honest, I don't know much about free PSA. So who out there knows something about free PSA?
A little bit. What was the free PSA number?
1.14.
So 1.14 and over, and 7.2 is the regular PSA?
Yeah.
So Gary, the PSA is like a lot of things that are transported in the blood. The PSA is bound to certain proteins, except for a small fraction that's floating free and unbound. And for men who have a rising PSA and they don't know whether they have cancer or not, you want the free testosterone to be higher, like I think greater than 25% of the total. Well, I mean, you already have a diagnosis, so I don't know what the point of ordering the free PSA for you was.
Yeah, to tell you the truth, Dan, it was kind of weird because this is my primary care person. I really like her a lot. She's a nurse practitioner. You know, she listens to my chest, feels my ankles, and basically we talk. You know, so she said when she ordered the PSA test for the first time, it's an outfit here called Health First. They automatically rolled in a PSA free request. So it was the first time, to tell you the truth, since I've had the disease, that I ever had a PSA free blood test, along with the regular PSA.
Yeah, some places may do what they call reflex testing, which is if the PSA is abnormal, they automatically run the free. They don't know. I mean, they probably don't know that you have a diagnosis already. So anyway, I wouldn't sweat it.
Yeah, I think that's exactly because, you know, they have that nice yellow, green, red, you know, when you get your blood work, you know, you want to be in the green in the middle. And of course, anything over 4 is what they call abnormal. So that's most why they did the free PSA thing. Thanks, Dan. I appreciate that.
Okay.
So Dan, could you explain it again and why it's used in the primary diagnosis, not after?
Well, my understanding is that when you go to the doctor, you have a PSA drawn, and if it's elevated, the free PSA should be, the higher the free PSA, the less likely it is that your PSA elevation is due to cancer. And my understanding is I think 25%, if I remember, is sort of the dividing line between, you know, good and bad. So, you know, for all of us guys who already have a diagnosis, getting a free PSA done is not going to do too much. The other place where you'll see free testing is when you have your testosterone drawn. They'll often do a free testosterone in addition to a total testosterone. And it's actually the free testosterone that matters, not the total testosterone, because the body only gets to use the free stuff. The stuff that's bound to proteins in your blood doesn't really count. And anyway, so it's just one of those funky medicine things that no one bothers to explain, but it's there.
Thanks again, Dan.
Martin, you joined us. Are you new to the group?
No, I'm not. I've been on several times. I just missed a couple, like I missed last week and the week before, but I've been on.
Okay. Do you need time today or no?
I'm good, thank you.
Okay. BJ, do you need time today?
I do have stuff, but again, I probably need to get prepared and ask a question. If there is time left, I'll ask a question.
Okay. All right, Gary, it seems since your PSA is down, married life agrees with you.
Absolutely.
Phil, you're next. What do you have for us?
Dan
I
has
just
a
had
question.
a PSA as part of my twice a year PSA draws, and my PSA was 5.7, which is good. It's been, I guess the highest it's been has been 5.8, and it usually bounces, but somewhere between 5 and 5.8. So everything's fine. I'm hoping I've got a micro ultrasound scheduled in December with Dr. Klotz. So that'll sort of be my, I think that may be my final sort of micro ultrasound. By the way, I put a note in the chat in case anybody's interested. There's a webinar tomorrow at 9 Pacific, so I guess 12 Eastern, out of UCSF with Matt Cooperberg, and he's featuring Lori Klotz and another doctor from Canada discussing micro ultrasound versus MRI. So it's in the chat if anyone's interested.
Okay, great.
Let's
Moving on.
Wait a minute, Ray. Wait a minute, Ray. We have Dan had his hand up.
Oh, sorry.
Yeah, so Dan.
Yeah, it's okay. I just wanted to mention two things. I heard you discussing some stuff before we came online formally with someone. It might have been Brian, about who had some prostate work done, and they told him to wait 3 months before getting a PSA drawn. And I always found that kind of interesting that they tell you to wait 3 months, but if we go for our routine PSAs, they tell us not to ride a bike or have a prostate exam or have sex for a day or two. So, somewhere in there, there's a disconnect. I mean,
Brian had an ablation.
Right. I understand.
I had the aquablation.
Right. Yeah, he had some surgical work done, but 3 months and a day or two. I mean, I've always felt that they're not telling us to behave ourselves for a long enough period of time. I don't think a day or two is enough. And
I agree with you. As far as
when I look at the literature, PSA has a half-life of like 5 days. That means if your PSA is 10 today, it's going to be 5 days from now if you don't do anything else. So I'm just throwing out the idea to the group that, to be on the safe side, I would take all the PSA precautions, and I would spread it out, more than a day or two before testing.
I do 5 days.
Yeah, Dan, I've told the story that, I went in and got a PSA one time, and it popped all the way up to 11. And again, the nurse, nobody had ever told me anything of what to do. And I said, oh gosh, I went I rode 65 miles like 4 days before or something. I thought it was going to be enough time. And they said, okay, well, obviously we'll throw that one out. And they, that's what they did.
Did you get it rechecked?
Yeah. I think it was, we waited another month or something and had it done again. But yeah, it's obvious that, at least a long ride like that can affect it. And before I knew any of this kind of stuff, I know that I went one time, I went like on a Wednesday to my urologist and had a PSA, and the very next day I got a physical, and they did another blood test, and they did a PSA. And in the meantime, I went for like a 25-mile ride the night before, and so that was 2 days apart, and definitely it had popped up by 3 points or some 2 or 3 points. So it definitely affects you.
Yeah.
So
I also wanted to mention, I might as well get it out of the way now. Can you guys see this?
Yeah.
I put this in the chat comments. I got this book. I don't know where someone sent it to me anyway. It's called Managing Prostate Conditions 2026. It's written with guys from Cleveland Clinic. It's about 70 pages, but the first probably 50 pages devoted to prostate cancer of all different shapes, sizes, and varieties. A lot of good statistics, stuff about treatments, percentages, impotence, incontinence, all the stuff that we want to know, but we don't really talk about in this group. So if you want some pretty current info, and there's an 800 number you can call. I think this was created by the guys that put out the newsletter called Men's Health. And I don't know, I might have paid $20 for it, but it's well worth it. So the information's in chat if you want it.
Thank you. Back to you, Ray.
Okay. Well, 2 people have their hands up.
Yeah.
Albert and then Israel. Albert, you had your hand up?
Yeah, I just wanted to know where Klotz and Cooperberg practice.
Cooperberg is out of UCSF, and Klotz practices at Sunnybrook Hospital in Toronto.
Thank you.
And Israel, did you have your hand up?
Yeah. I just had a quick comment on the PSA levels and taking a break in between the tests and whatnot. In a previous job, I had this what's called like an executive, like a physical basically. And this doctor, and this was before I knew a lot about prostate. I've learned so much since. This doctor did a DRE on me before he did the PSA blood draw, and needless to say, it spiked my PSA tremendously, like double, triple. I mean, it really spiked it. It scared the crap out of me. And but then after talking to my regular doctor, my urologist, he said, yeah, the doctor messed up. I mean, why would he do a DRE right before he did the blood draw? So at the end of the day, I mean, doctors are not infallible. I mean, the guy made a big mistake and scared me for like a couple of weeks, but it was just something that you just got to be on top of.
You bet.
And Israel, you're up next anyway. So what do you got for us?
Yeah, so I've been kind of in and out of these meetings. I've been just a kind of a recap because it's been a while since I've been on. I've been dealing with a BPH for like 12 years. I've had elevated PSA for like 12 years. I've had multiple MRIs and multiple biopsies. And luckily, thank God, my recent biopsy was negative, and I had it double checked with the doctor that you guys recommend, and I even had a 4K test and everything. And so that's the good news. And so, but I'm still dealing with BPH. So I had the Resume procedure done last year, and it helped a little bit, but not enough. And so I had a cystoscopy today, and luckily my bladder is okay, because I was concerned about, you have BPH for so long that eventually it's going to screw up your bladder. But luckily it hasn't. And so I'm going to have the HOLLA procedure done sometime in April. So I was just curious if anyone had the HOLLA procedure before, if they knew anything about it. And I just also wanted to comment, someone mentioned about the free PSA blood test. My urologist gave me the PHI, the Prostate Health Index blood test, which is kind of a combination of free PSA, total PSA, and something called P2 PSA or something. So anyway, so that was kind of his indicator that if it was on the high side, that's when he sent me to MRI. So that's another blood test, just to consider. So anyway, that's where I'm at. And I was just curious to see if anyone had the HOLLA, comments. Thanks.
I don't think anybody on the screen has had the HOLLA. Am I correct?
My 90-year-old, well, he's 92 now, but he was 90 years old. My father-in-law had the whole procedure, and it worked for him. He had like a 300 cc prostate, so
Wow.
Whoa.
yeah, so it worked. It worked for him.
Yeah, that's a huge prostate. Mine is, I think, like in the 88 range, 90 range, which is kind of like on the low end. But when I did a cystoscopy today, it's kind of interesting where you're looking at the screen and I mean I was pretty blocked at 88. I can imagine what 300 is like. So
yeah, it's the size of a small grapefruit, I guess. But yeah, no, it worked for him. So, but that's the only thing I can tell you. So. We've got a couple people join us. Mitch, you've been with us before, right?
Yeah, last week was my first session.
Right. Do you need any time today?
No, I'm good. Thank you very much.
And Dr. Wayne, do you need any time?
No, I'm good. Thank you.
Okay. All right. Moving on, Ignacio.
Nope. Watch, we got people with their hands up, Ray.
Oh, sorry. My mistake.
No problem.
Sorry, Dan, go ahead.
So I just wanted to mention Israel, first of all, just for the group. So the size of the prostate that they estimate or actually pretty well measure on your MRI, a prostate can grow out or it can sort of grow in and close the hole in the donut. And so people with pretty small prostate, if the prostate sort of tissue is growing more inward, they can get a lot of urinary obstruction. So the size of the prostate doesn't always correlate with how much urinary symptoms a person can have. The other thing I wanted to mention for Israel, two things. One is there are some resources online. There's certainly some in this book. I can look them up maybe later for you. But I think there's a lot of these BPH procedures being advertised, recommended, and you want to know, of course, how it works for your urinary problems. But another important consideration is what percentage of patients will need to get another procedure done within a certain number of years. And for some of them, it's alarmingly high. So I think that's one of the things you want to research. What's the redo? The mulligan, what's the redo for that procedure? The other thing I want to just throw out, which we discussed a lot, I don't know, a week or two ago, was for people who've been flirting with the diagnosis of cancer but don't have a diagnosis, it's nice if you can get a procedure for your BPH that will allow them to examine the tissue and make sure, because really in some ways this roto-rooter you're going to get is sort of like a giant biopsy. They're just going to take a lot of tissue out. And I think with some of the procedures, some of the laser procedures, the tissue is just basically evaporated. There's nothing to look at. So you might just want to, look at those two things. What's the redo rate for this procedure? And then, will there be any tissue for the pathologist to evaluate?
A quick comment on that. A quick comment, recomment, I guess, is the resume procedure I knew was going to have a higher redo, but it was a less invasive one. And they said they recommended that one first. But the HOLLOP is a one and done, and they have a very low, I think it's like 3 or 4% redo rate.
Good.
So yeah, that's why I'm going with the HOLLOP. And then, yes, they do check that was another reason why I like the HOLLOP is they do check for cancer on the tissue that they take out. So
great. All right. Sounds like you're doing your homework.
Oh yeah, thanks.
Albert.
Yeah, this is totally anecdotal, but I'm vegan and I have been like seriously for a year, zero animal intake. And to me, it seems like it helps with my urinary flow. And again, it's totally anecdotal. Might be totally off base. I know there's evidence or studies have said that veganism can help with prostate cancer. But in terms of urinary flow, it seems to me, for me, it's helped. I don't know, veganism has its risks with nutrient deficiencies and that sort of thing. But I just wanted to throw that in for your consideration. It's totally anecdotal though.
Albert, a question for you. Do you have your C-reactive protein taken, blood test taken regularly or every year?
No, no, I don't.
Oh, okay. It's a marker for inflammation. I was just curious if that went
Okay.
down with your, since being a vegan, but.
Okay. Well, and ironically, in addition to all this, it seems like my cancer is getting worse. My PSA is going up, and had a 4+3 after being 3+3. So I don't know. I just felt compelled to throw it out like it might help you, Israel.
Okay. Gary.
Yeah, two things. Israel, that HOLA procedure, I've read a little bit about it, but it's one of the newest on the block. So trying to ascertain some data might be a little difficult, but I would, as Dan said, I would certainly investigate it. It sounds like it's, and we've had somebody that has had it done, but I don't think they're on the call tonight. The other thing I wanted to ask Ray. Ray, what was that test for inflammation that you just said? What is that?
Oh, it's CRP, C-reactive protein.
CRP. Okay. Maybe the next time I do my 6-month blood work or whatever, I'll ask her to put that in the mix. I don't think that's not normally done in the CBC, is it? That complete blood count?
No, no,
Would be a special. Okay.
no, and it can reflect inflammation anywhere in your body, Gary. So, people with bad oral hygiene are going to have high CRPs, but this CRP is related to a whole bunch of bad things that can happen to men, especially heart disease, believe it or not.
Okay.
So it's a good number to measure.
Well, it's another example of things you learn while on the call, no matter how long you've been around, and that's wonderful. Yeah, I think Dr. Wayne's got his hand up, Ray.
Yes. Wayne, I think you're on mute.
Sorry about that. So a couple of questions for Israel. I came on a bit late, so I wasn't sure if you had considered aquablation rather than HOLA. And if you did think about it, what were your deciding factors? Because they both seem to have not only a low recurrence rate, but they give quite a good response when they're done compared to some of the other approaches. The advantage with the aquablation is that you can get a better view of the tissue if you're interested in looking for cancer compared to the HOLA, which destroys everything, as I think someone said. And the other point I wanted to mention was your comment about veganism is good. I'm vegan myself, but I can't say it's helped my BPH at all. My prostate has grown steadily from about 69 cc's in 2019 to 88 now. So I'm looking at either doing aquablation or maybe HOLA. I'm leaning more to aquablation though. So I'm just curious if you thought of that and if you decide against it and why. And the last comment I'll make is about the CRP, C-reactive protein. It's true, it's a matter of inflammation. We actually find that the HS or high sensitivity CRP is even more helpful than the CRP, in case you decide to go with that test, Gary.
High sensitivity, got it.
Yeah, but you have to ask for it.
Okay.
Okay, so Israel, maybe, did I miss your thinking about?
Yeah, no, I hear you. I did look into the aquablation, but the insurance I have, they don't. I mean, because aquablation is a lot newer than HOLA. HOLA's been around a little bit longer.
Yeah.
And I just didn't get a warm feeling that they had someone that's done quite a few aquablations,
Okay.
and so I felt more comfortable staying with the HOLA. And then the doing the test for cancer with the tissues isn't as big of a deal now as it was maybe a year or two ago, because I did this 4K test, and I mean, I have a high probability of nothing serious, and the biopsy was pretty clean. So I feel pretty, whatever I get out of it is kind of a bonus for me.
Right.
And then as far as the vegan versus the meat, I hear both sides of it. I don't know who to believe, and so I'm just kind of eating what I normally eat.
It won't hurt you. It won't hurt you, but
yeah,
it might not help as much as you think.
Got it. Okay, thanks.
Yeah, thanks.
Michael, you had your hand up before. Do you still,
Well, I was gonna throw my 2 cents in about the HOLLOP versus the aquablation because I looked at both of them and I talked to a doctor about the HOLLOP procedure. I think it's supposed to possibly have the lowest redo rate, but aquablation follows it very closely. One thing I would say, you were mentioning insurance now. Medicare gives a lot of pushback on paying for aquablation, but they'll pay for HOLLOP. If you have prostate cancer. Now, I don't understand that, why they won't do that, but they don't want to pay for it. Aquablation, if you are a prostate cancer diagnosed patient. Also, the HOLLOP, has very little bleeding, and if you're on any anticoagulants, anything daily or anything, and that's a much better procedure for you. I did the aquablation, and I can tell you I had not life-threatening bleeding, but I had quite a bit of bleeding.
Yeah, you did tell us that. Yeah,
significant
Yeah,
amount.
I mean, these are all really good comments, and I think one of the things, because like I said, I've been dealing with this for forever. It seems like my initial urologist, and it's kind of true. The urologist that specialize in a certain procedure, that's what they push. And my original one was really pushing the TURP. And of course, I did some research and this and that. I'm like, man, I mean, TURP seems so old fashioned compared to, HOLLOP or some of these other procedures. And I kind of went back and forth. And finally, I just said, you know what? I mean, you're fired. I mean, I ended up going with another urologist because he was stuck in his ways. He didn't want to look at other, like I would throw out, well, what about this? What about that? And he'd be like, nah. I'm like, forget that. I'm moving on. And I'm happy with the urologist I have now because he happened to be the one that did my resume procedure only because he was a specialist in this area. And when I said I wanted to do the HOLLOP, he didn't give me any, pushback and said, oh yeah, you got to go to this doctor because she's this expert. So, I think you got to be really careful with these doctors because they're going to really sell you on what they were trained in. And he's an older doctor and, he is what he is. But I mean, you got to be your own advocate, my point of view.
I would agree
Excellent.
with you 100%. I ran into that with one of the urologists I talked to that's in my community. I just had 1 or 2 appointments with him a few years ago, and he was like, "TURP, that's just the only thing you should do." and then he's a great guy, and he's not that old, and he's a great guy, but he was like very, very adamant against any focal procedures for prostate cancer. But on the other hand, he's very pro active surveillance. So it's kind of like go figure. I mean, his statement about focal procedures was he said, as long as you want to, he literally looked at me and he said, as long as you want to come and see me, I'm happy to see you. But if you have a focal procedure, I don't want to be your doctor.
Damn.
Yeah, I think the doctor-patient relationship is so critical because I mean you have to have a good relationship with them, and I'm the kind of guy that I get kind of like anxious. I mean, I have medical anxiety, like the biopsy, this and that, and my PSA is up, and this doctor, good, bad, or indifferent, he was like like cold stone, no emotion, like deal with it, it's not a big deal, and I'm like, are you kidding me? I mean, I'm going crazy over here. So anyway, at the end of the day, you got to feel comfortable with your doctor, at least in my opinion.
For sure. That's very important.
Absolutely. Mitch, you have your hand up.
Yes, thanks. So to Gary's point earlier about the new kid on the block, I wonder if any of you guys have heard of PAE, prostate artery embolization, as a procedure for BPH.
Yeah,
I've
does.
heard of it and read about it. It's
The only thing I'd say about that is that the need to repeat the procedure seems to be fairly high. So that's one consideration that you need to factor in, as we were discussing earlier. But it's becoming more and more available in more centers, and it's relatively easy to perform by those who've been doing it. The bleeding and the stuff that you get with aquablation does not seem to be an issue, but I think the recurrence or the expectation is that in about 5 years, you may have to repeat the procedure.
Yeah, so again, it might be an age-dependent thing where you're more comfortable a little further along to get it done. It's an outpatient procedure too, where some of the other procedures you have to admit it overnight. And there's anytime you go in the hospital, there may be some risk of infection, or even with an outpatient procedure, I suppose. But yeah, fairly straightforward to do. The other thing I wanted to mention is another dimension to looking at which procedure one chooses would be that column of potential side effects which affect sexual function, erectile dysfunction, incontinence. And all these procedures have a profile, and some perhaps like aquablation and PAE are less than others. TERP is notorious, I hear. So that's just another thing I'm sure that all you guys are thinking about too.
Good point.
Okay, Brian, you have your hand up.
Yeah, I'll just say I had the aquablation, like Michael, I think, had it. I had it like 3 months ago. And it was, for me, it was the best thing that ever happened. It was just like, oh my God, it's just I can pee again. But before I did it, I didn't know what to do. So they tried to tell me I should do the green light. What is it? The green light laser surgery or whatever.
Yeah.
And then I decided not to do that. And then I found the doctor and I said, well, how many of these aquablations have you done? He says, and he's done more than anybody at the hospital near Seattle there. So he did 60 of them. In the hospital, he had done like 250. So he was like the main dude. So, because I heard you guys talking about that. So I don't know if 60 is enough, but he did 60 of them. And so that's kind of how I decided to do it. The VA hospital didn't do it. So they did me community care at another hospital. So that's how I got that. I think it was about 50 grand or something like that, for 30, 40, 50 grand for everything, for the stay one night in the hospital. I had bleeding in the urine for 30 days afterwards, which was normal. And then it totally went away. So I've had no problems. Great. So that's my experience with the aquablation. I just thought I'd throw that in there.
Excellent.
Yeah.
Okay. Dan, you had your hand up.
So I was just going to weigh in on the dietary thing. You know, this whole concept got started because these epidemiologists looked at the prostate cancer risks in countries like Japan and China, where people don't eat as much meat and dairy as we do, and it's pretty clear they have much lower incidence of prostate cancer there. But so these are people who ate a certain way their whole lives. They're also, most of them, not as heavy as Americans and don't eat as much junk as we do. So, you know, to say if you started following a vegan diet when you're 50 or 60 years old, that it's not really helping is not totally fair. And it's certainly going to potentially, if you get your cholesterol and stuff down, it's certainly going to potentially help with your cardiovascular risk, which is still the things that kills more of us than anything. I also just wanted to read briefly what it said in this monograph, this 2026 monograph about prostate artery embolization. It says, in general, prostate artery embolization should be reserved for men with very large prostates and severe BPH symptoms who don't respond to or cannot tolerate medications, and cannot undergo surgery due to an increased risk of bleeding or other potential complications. It may also be ideal for men who cannot stop taking blood thinning medications. So it's got a place, but it doesn't sound like it's a first line for most of us.
Got one more. Phil had his hand up again.
Yeah, I just put a link on aquablation versus HOLIP into the chat. So if anyone's interested, there's a really good AI summary of it with a chart that shows differences between the two procedures.
Thank you.
All right,
back
Martin,
to you.
Martin, you have your hand up?
Yeah, hi. Can you explain the HOLIP or HOLIP, whatever it's called? I've never heard of it before. So if I could someone could just give me kind of like the 411 on it.
It's a laser procedure, as I understand it, and they take the tissue out with a laser, and I forget the name of that laser. It takes out the allegedly what I read the most amount of tissue. Problem is that it does have a pretty high rate of 3 months worth of incontinence, and I think a 2% potential for permanent incontinence. Because it's the laser, it self-coagulates as they take out the tissue. So very little chance of bleeding potential or problems there.
Well, that's good. No, thank you. Again, I appreciate that. Thank you.
Anybody
Martin,
else?
As Phil mentioned, if you can get to your chat.
Go ahead, Gary.
Yeah, I was just going to say, Martin, as Phil mentioned, if you look in your chat, you've got the last aquablation versus HOLA. If you research that website, it's an AI comparison of one against the other. Maybe it'll answer more questions for you.
Thank you.
Did you get that? Okay, Martin?
Yeah.
Okay, good. That's it.
I'm good. Thank you.
Guys.
Appreciate it.
I think we're on to Ignacio now.
All right, thank you. So the only reason that I asked for time was to give an update. I had a Zoom call today with Dr. Carroll at UCSF. And so just to set the stage, I have a high volume 3+3 with 2 cores 3+4 with a small amount of 4. The results are that we essentially went over the favorable attributes of my situation as well as the unfavorable ones, and I came away highly impressed. I cannot speak highly enough of Dr. Carroll. He essentially said that I should have another MRI prior to the first year anniversary of the last MRI, which, it kind of surprised me. And I also thought that he would order a biopsy, since it's been about a year and a half. And instead, he said to have a biopsy, but after the MRI. What I want to say here, though, is that just to offer hope to those who are in a similar situation. I also have a PIRADS 4 and a PIRADS 5, which are usually it correlate to high to aggressive disease. He placed a lot more weight on the fact that I do not have a crib reform pattern, and to the fact that that my decipher and genotype, what's it called, GPS scores are low. So the other thing that I came away with is that he also said that it is possible that I might need treatment sometime down the line, but he does not think I'm there yet, and that if I do have to get treatment, that the rate of success is high. And he also said, and this pleased me to no end, is that my odds of dying from prostate cancer, even though I'm high volume, are extremely low. So it could happen, but extremely low. His concerns are my high PSA density, because I have a small prostate. And the fact that I'm a fairly high volume with half of my cores being positive and 2 of them being 3+4. So so that's essentially all I had, and just to offer an update.
So Ignacio, I just wanted to go a little bit with, you seem to have come away from this really with a calmness, with really feeling great that you got the right doctor.
Oh, 100%. He is my third urologist, and the reason that I think he's fantastic is that he takes a conservative approach, as do I. I am obviously, not the type to say, "Oh, I have cancer, get it out now." No, that's not me. I'm more will take it out if I absolutely have to take it out. And and essentially what drives that, at least for me, is that as an example. So prior to the visit, I had to fill out three or four self-assessment forms that deal with like sexual function, urinary function, bowel function, and so on. And I present absolutely no symptoms whatsoever. So the only thing that I've been told is that I have cancer, but otherwise there is absolutely nothing, either in my ugly appearance or my behavior or anything that would be indicative of having cancer.
So I just love to hear how how well you feel, and I want to say that a good portion of that too is coming here. I know you've gotten you're active, you've done a lot of research.
Oh, yeah.
You're here, you're hearing these things. So when you were hearing your doctor, you knew that he was competent in the things that he's saying. I had that happen to me where I just had this calmness go across me that just I felt like, wow, I'm really, really in the right place. And that's what we're trying to do here is to
I mentioned that actually. If I had to pinpoint the hardest part of this journey, it was the anxiety after the initial diagnosis. But after you assimilate that, you research, you advocate for yourself. Again, I'm on my third urologist. Now it hardly affects me at all, aside from PSA tests and MRIs and the unfortunate situation with biopsies, which I don't look forward to, but it's a small price to pay.
Well, that's fabulous. I'm really happy for you, man.
All right.
Ignacio, may I ask a question?
Yes.
So are you in California? Did you see Dr. Carroll personally first before the Zoom?
I haven't seen him personally yet. I've seen him over Zoom twice, and both times I came away highly impressed and happy. And I should add yet again that I owe it to Rick. He pointed me, towards Dr. Carroll, and for anybody who is in the San Francisco Bay Area, I strongly recommend him.
I was wondering, is he available I'm in Florida. I would love to consult with him on Zoom, but we have state line barriers, I guess. Is that so?
Yeah. So, Mitch, before you go further, my understanding is he's not taking any new patients. So,
thank you.
Ignacio's been with him a while. We got him in under the wire, but we've had other patients recently that we have suggested speak to Dr. Carroll, and the answer that comes back is that he's not seeing new patients. So if you're already with him, you're in good shape. If If you're not
I'm not
with
letting
him,
go.
it's not going. It's going to be a stretch to get you in. So I would take it out. If you're looking for a good second opinion in Florida, Sanjay Punar is really good.
Could you spell that for me?
I'll put it in the chat window.
Sanjay Kumar?
I'll put it in the chat window. Do you know how to use the chat window?
I can't find the chat window on my screen, so.
Well, you start with taking a look because it'll help you a lot if you come to our meetings regularly.
Yeah.
I'm gonna put a link to Dr. Punar in there, and there may even be some people in this meeting right now who see him who would speak up for him. He's in Doral, and he works out of Sylvester. He's associated with Sylvester.
Okay, thank you very much.
Gary, you're up.
Yeah, thanks. I just wanted to reiterate what you were saying about Ignacio, because I've been around for a while. I guess maybe when Ignacio jumped on board, and he's a good researcher, and he was a little bit more nervous and jerky in the beginning. And I think that we and Rick Davis and this group, he's another example of why this is basically priceless. Getting people to put you in the right place at the right time, introductions. As a matter of fact, I'll just speak for a moment. I want to get a biparametric MRI in February. I normally go to Mayo. I might get some resistance from my urologist at Mayo. I hope not, but I don't want to hear it. I don't want contrast. I want to get in and out of the tube. And there's 2 big studies out there that say it's just as good. I happen to mention this to Mr. Walensky, who has always been an integral part of ANCAN and the active surveiller, of course. And he, in fact, told me, well, if you get pushback, show him the studies. You still get pushback. And he sent me all the links. He says, if you still get pushback, go see Dr. Punyan down in Sylvester, down in Doral. So this is the kind of thing that we can do for people. This is what the support mechanism is all about. And Ignacio, I'm really happy that you feel really good with Dr. Carroll. And of course, you know you're in a good place. So that's my 2 cents about that. Thank you.
Thank you.
Israel, you had your hand up.
Yeah, a quick suggestion for Ignacio, if you haven't done it already, Ignacio, when you do the biopsies, because my first biopsy was torture, but it seemed like they get better over time. I don't know if it's a technology or whatnot, but I took some anxiety medicine, and it really helped me this last one. I mean, I wouldn't say it was pleasant, but it was a lot better than before. So it might be something to consider. Check with your primary or urologist.
So I've had 2 already. And both of those have been rectal. Now I've asked for a transperineal. I don't know if that's going to be easier or harder, but the 2 that I've had, they weren't all that bad.
Yeah, I think that becomes a personal thing, people, between transrectal and transperineal. Of course, we at ANCAN and all of the UK, certainly on the transperineal train, because it eliminates the need for antibiotics and eliminates the chance of sepsis. The chance of sepsis is low with a transrectal, but as I've said before, I don't care if you're 1 out of 10,000, you don't want to be that guy. Yeah, right. You don't want to be that one. So if there's a way for you to avoid being that one, I'm going to jump on that every time. And of course, I get knocked out completely when I do it. So feel no pain, and I've had no problem at all with after effects other than a little, blood afterwards. So, but that, of course, is always a big debate, but we always advise and try to seek transperineal biopsies. Okay.
I'd like to ask if I have an extra 30 seconds. Has anybody heard of a precise score? Well,
What?
okay.
Well,
Yeah, nice.
well, I missed what you said, Ignacio. Can you say it again?
Precise score, and my
Precise
understanding.
score. Yeah.
Yeah, like if you ask precisely what is a precise score, right?
Right.
The precise score, the prostate cancer radiological estimation of change in sequential evaluation is a 1 to 10 scale used on a follow-up prostate MRI for men on active surveillance, assessing if suspicious lesions are stable.
Right.
That's what it is.
Well, the reason I ask is that he suggested that I have an MRI, which obviously I will have, but it will have been less than a year since the last MRI, and I'm hoping that since it'll be done at the same facility, that they can compare the two and offer a precise score, which essentially is a measure of have lesions grown, have they stayed stable, or have they actually shrunk in size? And it's my understanding that if that value is favorable, in other words, either stable or shrunk in size, that is highly indicative of the cancer not being aggressive.
I would agree with you.
Yeah.
And if you get that result and don't have much of a change, I mean, in my case, Ignacio, that's, as long as there's no change on the MRI, I've avoided biopsies. So that's what I'm sure.
I gotta admit that is, part of the reason I'm asking is that if
and I would agree with you. I'd want the MRI as close to a year apart if you can.
Yeah, right.
Dan,
thank you.
Ignacio, I may have shared, with you one time before. The last time I went in to the doctor, I thought I had him because the report that I had on the MRI the guy had referenced an MRI from 2 years prior and not the most recent one. So I said to the doctor, I said, well, wait a minute, this guy has missed an MRI. And he said, no, actually, what we want to do is we compare them with all of your previous MRIs, but we usually can see more of a change over a 2-year period than a 1-year period. So that's why it's so important that you keep on getting these, and the trend is your friend as you're building your database and they're looking back across these things.
Sounds good. Thanks.
I think we still got Dan has his hand up.
Yeah, I just wanted to mention briefly for Ignacio, who doesn't like prostate biopsies, and I don't blame him, that my understanding is if you can find someone to do a transperineal biopsy, they usually put you either under twilight or some type of anesthesia for that. So you won't need to take Valium or something else if that's what you're going to have. And for most of us men who are, no guts, no glory kind of guys, even if you're going to get a transrectal, whatever, I found 2.5 milligrams of Valium. It's like a panacea. Whatever's bugging you, you're not going to worry about. So I'm a lightweight. I'm a lightweight. Maybe you need 5 milligrams, but whatever. Don't suck it up.
And in my case, I haven't been bad. Having a crown on a molar was worse than.
Okay. Let's see. We still have Albert and BJ. Albert.
Yes,
Had a
Ignacio, I just wanted to ask what your Decipher score was.
0.13.
Oh, that is good.
Very low.
Okay. And I'll share, I had a transperineal without Valium or any anesthesia. I just had local. And it was sharp pain, brief but sharp. I didn't want to go through it again. So I went to the twilight anesthesia for my next transperineal. It was a breeze. I really liked it. I'm not going back to in the office without general sedation, except maybe this idea of Valium that piqued my interest of like, maybe if you take Valium, it is okay in office, but that's what I experienced. Thank you.
Thank you.
DJ, you had a question?
Yes, I just wanted to congratulate Ignacio and also let everybody know that we both went to the same high school. Of course, I'm younger, excuse me, he's younger than me, but the source of his intellect definitely is Bellarmine College Prep in San Jose, California. So just for everybody's information.
And Phil
Hey,
and
I think we got Roger. Roger.
Yeah, you know,
Yeah.
I mean, I've had five biopsies over the time I've been on active surveillance. I never had any. I was never put out. My last one was a transperineal, and honestly, it wasn't any easier or any worse than the previous. I mean, so I guess it really is individual.
Yeah.
Okay.
Okay.
Mitch?
Yeah, so excuse me, back on the topic of aquablation, just to follow up, there was a webinar, I think it was one of Howard Walensky's a few months ago, and he brought in a doctor, a urologist from Chicago named Helfand, I think.
Yeah.
A young fellow, and he is doing some pilot studies where he does aquablation procedures targeting suspicious lesions, which are then biopsied and then following up and management, the PSA and the other markers after specifically removing suspicious tissue.
Interesting.
Dr. Helfand would
like
be
a
very
phone
happy
therapy.
to hear you call him a young fellow. That I can certainly tell you, because he's highly experienced. He's been around a long time. We've been working with him, I don't know, 7 or 8 years, maybe even more. So he's not he's of the ilk of, say, Cooperberg, more senior than Cooperberg, a little less senior than Peter Carroll, but he's way up there. I'm not personally familiar with the technology you're talking about or that study that he's doing.
Yes, I have a daughter in Chicago, which I visit several times a year. And next time I get up there, I'm going to look up Howard Walensky and finally meet him. But I made an appointment to see this Dr. Helfand. I don't think I can do the procedure with my insurance up there, et cetera, but I'm going to just get his opinion and see what he says about everything.
Okay, and if he's not wearing his Ancan sweatshirt, ask him why.
Will do.
If you go on our website and type in Helfand, you'll probably find the webinar that he did for us. In the search, type in Helfand in the search box.
Excuse me, go ahead.
No. Okay. Martin, you had a quick comment?
Yeah, I saw Dr. Helfand yesterday. And he is a young fellow. At least being a 67-year-old man, he definitely seemed young. He's fabulous. And he one thing about this trial, though, he was talking about is that the aquablation trial is that 75% get the aquablation and then 25% get the prostatectomy. So you have to be very careful if you sign up for it, because if you aren't part of that 75%, then you have to have that. So I chose not to do the trial for that particular reason. but Medicare, as you said, Michael, does not cover it. But he spent a lot of time with me and my wife yesterday, and basically said that I should be on active surveillance. And with my low, even though I have a 4+3, it's so minimal that he feels that I should do that. So I was happy to hear that.
Martin, you're
is that
4
a 3
plus
plus
3 or
4
3
or
plus
4 plus
4?
3?
4+3. But it's there is 0.05 millimeters. And there's another one which is like 0.007 millimeters. And I had spoken to Dr. I'm sorry, Dr. Spratt in Ohio the other day, and he suggested radiation. And health fans said, but why? When you hardly really have anything, a very small prostate, your PSA is 2.24. If it's not broken, don't fix it. At least that's the plan now. I am seeing Dr. Liao next week at UFC to see what happens there. But I was really impressed with Health Fan. He was pretty phenomenal.
Okay. Moving on, Albert, what do you have for us? We lose Albert.
Albert, you wanted some time.
Got it. Yeah, here I am. How do you spell Hal, friends?
It's HELFAND. First name is Brian.
HELFAND?
Yes.
Great, thank you. Okay.
You're welcome.
Yeah, what I've got is Epstein got my slides. He's doing his second opinion. I was hoping I'd have it by tonight. He couldn't quite get the study or the results back to me. I was supposed to have a PSMA done yesterday at Mayo. I chickened out so that I could get this second opinion, and also Rick and others had recommended maybe I wouldn't need a PSMA based on what Epstein says. So anyway, I don't know what's going to happen with that yet, so I'm waiting. Once I find out where I'm at, then we'll see if treatment is indicated, and then maybe I will need some sort of urologic oncologist to help me guide my way. I don't have anyone that's really guiding me. Yeah, I'll just wait and see on that. My PSA has been going up. It was up to like 9.1. Let's see, in August it was 9.77, then it went to 11.1 in September, then 10.4 in October, 9.4 November, and then this year it went to 11.2, and then yesterday at Mayo, some of these are Quest, some are at Mayo, and I know you can't compare them because they're different assays, but yesterday at Mayo it was 12.2. So something's going on, and it's got me pretty worried, but I'm trying not to overreact, and I'm really just waiting on Epstein at this point. And I don't think there's really anything else to report or do at this time, unless anybody else has any recommendation.
I'd get the results back and come back.
Yeah.
That's what we discussed last week.
Yeah.
Yeah.
Okay. Thank you.
Moving on, Roger, you're up.
Okay, thanks, guys. I've been on active surveillance for 5 or plus years, covered by Rochester Mayo, and I've had multiple biopsies, MRIs. I'm a 336. Most recently, the PSA has been climbing, kind of similar to Albert there. It was like 7.5 back in April, and then 9 in October, 12 in December, and January here it was up to 13.8. Now I did have a MRI in early December, in the middle of this. That came back PIREDS 2, so good report. The prostate size had grown to 96, up from like 86 earlier in the year in April. So the density is still underneath that glass ceiling of 0.15, but just barely. It's like 0.14. So now Mayo is talking about another biopsy, and I've had, like I say, I think 3 total. When I had Ming Zhao reread my results of a earlier test or biopsy, he knocked it back. It was a 3-4, but he knocked it back to 3-3. But he told me, he said, I wouldn't have too many biopsies, unless you absolutely have to. And so I kind of feel like I'm in that point where I probably should. They're recommending that I should do a biopsy. I'm leaning in that direction, and I'd be open to anybody else's comments. This has always been a great group for me. But I think that rising PSA over a relatively short period of time kind of trumps the PSA density. Anybody have some thoughts there for me?
Couple questions. Did you ever have a Decipher score or any type of genomic testing of your tumor?
No, I think that's, I'm going to bring that up to them as we go into the next. And I have a couple of aquablation comments very quickly at the end, but so no, thank you for that. I will be asking for that.
Okay.
How old are you, Roger?
70.
Okay. Yeah, I
Oh,
think
the PIREDS.
the PSA rising like that, I think I'd have my, I'd be curious as to what your doc is saying.
Yeah, so the biopsy, I asked him about a biopsy. I said, so when I get back a PIREDS 2, are you going to go back and biopsy the areas that were in question before that had a little cancer? I think I had one core and one of the, with less than 5%, and he said, no, we're going to do basically 14 all over the place, which seems like, I guess that's what they have to do, and I'm taking their recommendation, but I would have thought they would have gone back to a place that had been targeted before, but I guess not. So
they might be with the rising PSA. I think they may be wanting to take a more of a scatter shot,
Yeah, I think so, Hugh. So I'm going to go ahead and do that, I believe. I wanted to make 2 quick points that I think are very important from Mayo. My guy, because I wanted to do the aquablation. It's been hard to urinate and void the bladder and so on. And it's more annoying for me than it is really debilitating. But at the end here, because of the rising PSA, he says, I don't want to go in there and do the aquablation until we figure out what's really going on. But he then mentioned that the tissue that you take out, because I had read that you can have the tissue sampled, but he said, yeah, but that tissue comes from the center of the prostate. So that's not where cancer usually is. Cancer is usually on the periphery or edge. So you're really not doing that much. It's not that accurate to pull that material out. So that's one point. The second point about aquablation is that if you have that done, it makes it more difficult to do a radical prostatectomy if necessary. It's harder to execute after you've had that aquablation because you've been messing around in there. So it's more likely that they could cause a side effect like leakage. And then at that point, you'd be limited. So to not do that, you'd be limited to radiation. So he said to me, if you're okay with only doing radiation, if you end up having a problem, then fine, we'll do the aquablation. But so that was kind of a sobering point to me. So I thought those were 2 very interesting situations relative to aquablation. But thank you.
And you have a comment?
Yeah, 2 things. First of all, and this is really important because we spend so much time talking about PSA. This book from Cleveland Clinic, or it might have been something I heard in a blog, but I heard that a rising PSA alone should not be a reason for discontinuing active surveillance. So I don't know if that's helpful or not, Roger.
Yeah, I'm not, I agree with you. I'm not planning on doing anything until it's the question for me right now is just doing that extra biopsy. And yeah, it's no fun to get your rear end punched, but you know, it's okay. I get through it, but I just come back to a guy that I respect because of this group that I keep coming back to, Ming Zhao, who just said, you know, don't do it unless you absolutely have to. And so I think I have to with another biopsy. Um, and then make decisions from that point. But I agree with you, the rising PSA by itself, but it's getting pretty high, I have to say.
Yeah, but as you mentioned, your prostate's growing, so that's the most common cause of a rising PSA. But so I think you're doing the right thing. You're taking it seriously. You're going to investigate it. But you know, my understanding from looking at NCCN and some of the other guidelines, 10 is where guys start to get nervous, and then 20 is where, you know, things start to change. So, you know, you're not there.
Right. To your point, Dan, Howard Walensky, I was talking to him the other day, and he showed me some research from China that actually has been showing that the PSA density is more like 0.4, you know, way higher before they start to get nervous. Now, again, I couldn't pull up the research because it was behind a firewall or a paywall. Not that I wouldn't have paid it, but I figured I'd ask Mayo about it for starters before I make any decisions. But good point, Stan.
But I think the main thing about PSA density, Roger, is that PSA density is useful for someone who doesn't have a diagnosis, who has a small prostate and his PSA is going up. The PSA density gets over 1.5 and they say you need a biopsy. You've already had a biopsy, you already have a diagnosis. I wouldn't hang my hat too much on PSA density now. It's already you're past that point in the algorithm.
Good point.
Can I make a comment about PIRADS?
Sure.
I also have a PIRADS 3 and it's been stable. It has been sampled twice on biopsy and has been negative for cancer. However, my cancer diagnosis came from an area of the gland that was not PIRADS rated at all on the other side, which alerted me to the fact that there are lesions which are invisible to MRI, and that PIRAD lesions, on the other hand, can be caused from fibrosis or prior prostatitis or other things. So I wouldn't focus too much on going back and targeting a PIRADS for biopsy if it's already shown itself to be negative. It may be somewhere else. And I do have a biopsy coming up, which I'm trying to avoid, but it probably won't. And what I've done this time is I've enlisted this company called Artera AI, and they will take my MRI findings. And what I do is I take the disc after the MRI, and I'll take it home and make it into a zip file and upload it to them, pay them $259 private pay, and they will within minutes give me an AI read on where the most suspicious or aggressive tissue might be in that MRI scan using AI. And I will take that to the radiologist and the urologist before the biopsy as a supplement to see if they can possibly target that tissue.
Yeah, it's interesting you said that. I actually uploaded my last 2 biopsies into ChatGPT and asked it to give me a readout and a print of the colored, you know, and it was amazing because it pinpointed exactly where they said it was. Crazy good.
Interesting. Yeah, there's a couple of case studies that Artera lists on their website where targeted biopsies have gone into the MRI identified suspicious areas and totally missed the most aggressive lesion. When they lit it up with AI, it was a few millimeters away.
Interesting, yeah. Well, thank you guys for your time. I'll be back with more later.
Okay.
All righty.
BJ, is he still on?
No, he left.
No, he left. We've got a couple of hands up, Ray.
Yes. Oh, yes.
Yeah. Can I make a comment to follow up on what Mitch said? I had the opportunity to attend the PCRI conference twice, and from a talk by Dr. Klotz, he emphasized that lesions that do not show up on MRIs have a tendency to not be aggressive cancer. So the fact that it was found on a part of the that it's a lesion, or it's a Gleason grade 3+3 or higher, if it's not seen on MRI, that tends to be a good sign. And if you'd like, I can see if I can find the paper, but that was a takeaway.
Thank you, Ignacio, for reminding me. I had heard that a while back. Yes, thank you very much.
Dan?
So I just want to also mention, since all of us have had biopsies, one of the, I don't know if it's a common, but one of the causes of PIRADS, 1 or 2 lesions, is a hematoma. As you know, we all had some bleeding after our biopsy. Well, bleeding into the prostate, it calcifies and it shows up on future MRIs as a PIRADS lesion with a very specific appearance. The radiologist usually doesn't have too much trouble distinguishing a hematoma from cancer. But so yeah, just remember that if you're going to get needles poked in your prostate, you probably won't have a pristine, clean MRI next time you have one done. And also, you should understand too that MRI has a resolution. I mean, it sees down, in the old days, CT scans had a resolution of about 1 centimeter. They wouldn't see things much smaller than that. I don't know what the resolution is for MRI, but it's not a miracle. It doesn't see everything down to the micromillimeter level. So understand that you can have small things in your prostate that aren't going to show up. But as was noted, those small things are not that likely to have already metastasized, which is what we all kind of are concerned about.
Hey, Ray.
Yeah, anybody else have anything?
Oh, I'm sorry. Could I make a correction to something I said earlier?
Sure.
The company that looks at the MRI images with AI is called B-O-T Image, and not Artera AI. Artera AI looks at the pathology slides.
Hold on, isn't Bot Image our friends we did the webinar with?
Yeah. Mike's company.
Yeah, that's how I found out about it.
Okay. Well, Ray, I think you got everybody. Is there anything else?
Anybody else? Any last questions? Anybody has anything to say? If not, I think we can wrap this up.
Great.
Have a good evening, everyone.
Okay.
Thank you, everybody.
Good discussion. Thank you, everybody.
Moderators, stick around.
Good night,
Wow,
everybody.
this is a record.
Yes.
9:20, unbelievable.
Yeah.
Great job, Ray.
I'm
Yeah,
also
very,
one thing.
very good
Ray,
job.
Dan,
You
good
got
job.
them through. But
Rick,
one
while
thing that
you're on
I,
here,
one thing I did mention in the chat, I don't know if you saw it.
Wait, let me turn the record off.
Yes. Oh,